All right, so we're going to talk about esophageal atresia with a tracheoesophageal fistula. This is probably like my favorite surgery ever to do because we do it right at birth, and their little lungs are so squishy and pink and beautiful. Like, it's awesome. Well, not for the baby, I guess. But, so what it is, it's a failure of the esophagus to develop as a continuous passage, okay? So, you know, with normal, you see right here, this is normal. We've got the esophagus comes down to the belly, and then the trachea will come down and go to the lungs, right? That's what normally happens. With esophageal atresia, or if you have a TEF associated with it, it can happen all these different ways. You can just have like a little blind pouch. I'm making sure I go to it. Like right here. So the esophagus ends in a blind pouch and it doesn't connect to the stomach. Or you can have things where the esophagus has a fistula, which a fistula, you know, is just like a passageway or opening where it connects to the trachea. You could have the esophagus end in a blind pouch and the trachea actually attached to the stomach and the lungs. So that you can have it a bunch of different ways. The most common way is C. Like almost 95% happen this way. All right, where you have a blind pouch where the esophagus is, and that your trachea goes to the lungs and to the stomach. It's going to come back. Check breath. It's going to be okay. See, it's back. All right. So, clinical manifestations, it's the 3 C's. And I guess I'm going to get to the 3 C's in just a second. Sorry, sometimes I forget what I have up there in what order. All right, so in utero, they oftentimes have polyhydramnios, so lots of fluid. Because normally what would they do? Swallow the fluid? But can they swallow the fluid? No. And do we use our lungs in utero? No. So we don't use our lungs in utero. Remember, that's why we have that, you know, because they're full of fluid and we're not taking breaths. So normally what a baby would do is swallow amniotic fluid and then pee that amniotic fluid out. It gets reabsorbed, whatever. But with babies who have, you know, EA or especially with TEF, they're not swallowing that amniotic fluid, so that amniotic fluid builds up. So they have too much. They oftentimes have a low birth weight or are born premature.
Is this seen in utero, like they catch it, or not till the baby's born?
All things, sometimes we catch them, sometimes we don't. Sometimes we can see it, but a lot of times we don't. Most of the time they're diagnosed because we can't see that structurally that well. 4D ultrasounds are making it more possible for us to see things better. But remember I said one of the limitations of ultrasounds is that we can't always see because of fat tissue or other organs that are in the way. So it depends on the baby's position. And if the baby never gets in a good position or you're a healthy pregnancy with no risk factors, how often do you get an ultrasound? One time. So, you know, they don't always catch it. Most of the time you'll get diagnosed with the 3 C's. Here they are. Told you they were coming. There's coughing, choking, and cyanosis. So instead of their airway just getting air like it's supposed to, their airway is getting fluid. Because we have normal salivation, right, in our mouth. And whether we think about it or not, we're swallowing that. So that builds up for the baby, and they're not able to swallow it. Well, it's going to go down the trachea into their lungs. Well, we talked about that trachea has a protective mechanism, right? There's like a little flap, and when that little flap hits where there's fluid, you'll cough, and the cough closes that flap to prevent fluid from going into the lungs. So the baby is going to have like this increased salivation. They can't swallow it. When they try to swallow it, they cough or choke on it. Okay, so even without feeds. So do we want to feed these babies? No, because we're going to give them fluid directly to their lungs. So we're basically going to drown them or cause pneumonia or get them really sick.
So
Yep.
the upper half, the atresia, is that what it is? Atresia? The upper half of the esophagus, that's closed at the bottom?
Yep.
So it's still
It's a blind
it's
pouch.
never open at the bottom?
Once we do surgery.
Okay.
Yep. No, the atresia is that blind pouch. So and we're going to talk about treatment, but one of the ways, so we'll have a baby be born, and the baby will normally cry and then swallow and take its first breaths, and everything's fine. But what happens with these babies, they're cyanotic because instead of air getting in there, they're getting fluid, so they don't have that gas exchange that we talked about. And they're choking because you're still, even without being fed, they're still producing saliva. And that saliva doesn't have anywhere to go. And if you've ever tried to hold your mouth open, it's okay. If you ever tried to hold your mouth open, and as you start drooling, that's kind of what's happening to the baby. So they can only hold so much in their mouth. They start drooling. It starts backing up and going down. But instead of going down into the stomach, it's going down into the lungs.
Okay.
So, and that's what makes them cough, because their lungs are trying to protect and saying, wait, that's not supposed to be there. And when I cough, that flap is supposed to protect, but it's kind of getting inundated and getting too much. So they're cyanotic, they're choking, they're coughing. And so once we see that, that should be a red flag to you. And again, this is why you need to understand what's going on, because NCLEX wants to know that if you are a mom-baby nurse and you're in the delivery room and everyone's like, yay, there's a baby, and everyone's happy and wonderful, and you notice that this baby's really struggling, there should be a red flag that says, wait a minute, I'm worried about an EA with the TEF. So now what do we do to check it? So before we feed them, so if you're concerned about it, if you see the 3 C's, a baby kind of, they keep doing it after birth, they seem like they're choking, their APGARs, you guys did mother-baby, right? So those APGAR scores, they should improve within the first 5 minutes. If that's not happening, then you should have a red flag, something's going on. So if I'm concerned that's an esophageal atresia, then I'm not going to feed them because that feed is not going to go anywhere. So I need to figure it out before I feed them. I'm going to, obviously document the clinical manifestations, get a chest x-ray, because that's going to show me the defect. It's going to show that esophagus ending in a blind pouch. And a lot of times what they'll do is they'll stick an NG or some kind of opaque tube down the nose or down the throat, and they'll see that the NG, I'm spitting on myself again, they see that the NG doesn't go anywhere. They see that it ends in that blind pouch. So we'll try to advance an NG and it just doesn't go. So we are going to keep them NPO and start IV fluids. And we're going to keep that head of the bed up, right? Because we always want gravity to work with us. And we've got to remove secretions. So oftentimes we'll stick an NG down and put them on intermittent or continuous suction. Because again, they're still going to have salivation that we need to remove, even if we're not feeding them. A lot of times they get put on an antibiotic, like a broad spectrum antibiotic, because fluid does get into the lungs and we're worried that they might develop a pneumonia. We give them oxygen for any respiratory distress. So if for some reason they have, gotten a lot of fluid into the lungs, they're having some cyanosis, having some trouble breathing, we want to throw some oxygen on them. And then we do surgical repair. So what they'll do, especially because that C is the most common, they'll disconnect the fistula from the trachea. So they'll go in there right here. They'll go, am I pointing to the right thing? They'll cut right here and cut that open. They'll sew this trachea up. Then they'll take this in that they cut off. They'll cut this open, the blind pouch, and then they'll put those two ends together. I love this surgery because everything is so pretty inside. There's like no exposure to smoke or anything. Like when you think about like a pink spongy lung, this is what like they look like. They're beautiful. Their first feed post-op is water. You want to avoid any respiratory complications. And provide emotional support. So a lot of times with these kids, even though, so this is done right at birth. So everyone's happy, here's my healthy baby, oh crap, something's wrong. And they take these babies right away for surgery. They're a day old, you know, they're not very old. And now the mom is trying to recover from giving birth and thinking she has this healthy baby. And oftentimes, as the mother-baby unit in a hospital that can do this, the same hospital, not a lot. So let's say you delivered at Meese Countryside or Morton Plant, and your child's now at All Children's, and you're stuck at Morton Plant, and you don't even get to see your baby that's going for surgery. It can be really scary for them. So we need to provide a lot of emotional support for them, let them know what's going on, make sure we keep them in contact. We give them water first, because if God forbid those sutures pop open, we don't want formula getting into the, you know, cavities. They're at high risk for respiratory complications because they've gotten secretions into the lungs. So we need to be very vigilant about their breath sounds, about, you know, if we're worried about fever, a baby's not gonna say, I'm at risk for pneumonia. They're gonna have a fever, they're gonna have cough, they're gonna have breath sounds, you know, crackles. So we're gonna be looking for those things. And then this is oftentimes long-term because, remember, scar tissue doesn't act the same as normal tissue. So they get stenotic, Richard, this is where it comes into play. They get stenotic at that area where they sewed them back together. So oftentimes these kids have to come back every few months, every few years, get sedated, and get what we call dilatation. So they'll come, they'll get an endoscope, and they'll dilate that area. They'll dilate the scar tissue and kids might complain and say, you know, I'm having trouble swallowing, or I feel like food gets stuck. And we need to teach parents that if kids start complaining about that might mean that area is getting strictured and that the kid might have to come in and get it open. So they're often followed by surgery long term. So there is a 50% mortality rate because people don't catch it and they feed them and they choke and die. Okay? So that's why NCLEX wants to make sure you guys are safe, because we want you to not make people die. All right? So, but if we catch it and we do surgery, it's like 100% survival. So they do very well if caught. Like surgery-wise, they do great. And most of the time, this is their only anomaly. Now, obviously, if they have other anomalies because if they have a syndrome or just whatever, then they're going to have a poorer prognosis. But if this is their only anomaly, we catch it early, we treat it, they get their surgery, they do phenomenal. All right, any questions about that? Moving on. Pyloric stenosis. So this is an enlarged or thickening of the circular muscle of the pylorus. So everyone knows what the pylorus is? Just in case you forgot, it's okay. So the pylorus is this muscle right here, right right where the stomach is starting to go into the intestines. So what happens is that muscle, it's like a ring, it starts getting thicker and thicker and thicker. And as it gets thicker and thicker and thicker, you know, your whole, you know, food can pass through a hole this size to now trying to pass through a hole this size. All right. Oops. It happens, you know, pretty frequently, 3 out of 1,000 births. And it's 3 to 5 weeks of age. It's typically right about 4 weeks. They always come in around 4 weeks of age. It's those wimpy white boys that always have a problem. And there is a genetic predisposition. So, like, if a parent had it, the infant has a 20% chance or greater of getting it. Are those good chips? I'm being good. It's going to go back. Don't get upset. Take a breath. Okay, I'm sorry. All right, so how do we diagnose it? Mostly because the parents are going to tell us almost like the classic symptoms. They're going to give us a history, and we're going to do a physical exam. We confirm it with an ultrasound. So parents will tell us the classic symptoms, which we're going to talk about in just a second. And then we'll do a physical exam, and there are things that, you know, suggest it. Sometimes there's nothing on physical exam. And then we get an ultrasound, and we actually measure the so we'll say, you know, the infant is suspect of having a pyloric stenosis. The ultrasound tech goes and just specifically measures the pyloric muscle and sees how thick it is. And if it's a certain thickness, then they're determined to have pyloric stenosis. So, the labs we get, because we're going to talk about clinical manifestations in a second, these babies are vomiters. So, they are hungry. They want to eat. They eat, but the food can't pass through the stenosis, right? There's not a big enough opening for it to pass. So, they throw everything up. What do you get when you throw things up? What kind of, you get metabolic alkalosis or acidosis?
Alkalosis.
Alkalosis. Remember, ass is out your, right? If you think about that, metabolic acidosis is out the bottom. Out your ass. And then alkalosis is anything from the top. So NG, vomiting, anything like that. So these babies are at a high risk for a metabolic alkalosis. All right? So remember, when we're looking at ABGs, it determines whether it's alkalotic or acidotic is the pH. Okay? So if they're alkalotic, what's a normal pH? 735 to 745. So if they're alkalotic, they're going to be greater than what? 745. All right? The two other factors that we look at in ABG are CO2 and bicarb, which is HCO3. CO2 is respiratory related and more acidic. Bicarb is metabolic related and our base. Okay? So when we're looking at it, we're going to have a high or low bicarb. High. Yeah. Okay? So just kind of, I know this is, I don't want you to think too much about it, but I want you to kind of understand this because you're really going to build on it in 4. They're going to focus a lot on it. So, and then their sodium and potassium and chloride get out of whack. So it's really important to get labs on these babies. Once we suspect they have a pyloric stenosis and we confirm it with ultrasound, we immediately get a BMP, a basic metabolic panel. And if these values are out of whack, they will not do surgery until we correct them. So they'll get IV fluid. So sometimes they sit in the hospital for a day, 2 days. I've seen 3 or 4 days while they're correcting their electrolyte imbalances, just depending on how long they've been sick. Oh, just kidding. I just had all the answers. So high pH, high bicarb, metabolic alkalosis. All right, so clinical manifestations. On exam, there is a palpable olive-like mass. I worked for pediatric surgery for a lot of years. And I think I felt that stupid olive-like mass like one time. But they say that that's one of the classic signs. And it's just, you'll feel it like right here because that's where your stomach is meeting the intestines. So right in that area, you'll feel like a little, like an olive, like a hard little olive. I do not feel it often, but that's one of the classic signs from my experience. Maybe it's just I was a bad olive feeler. I don't know. But so they will say that they have the palpable olive-like mass. So if the baby comes in reporting a lot of vomiting, we'll go ahead and make sure. Because what's the other thing that they might get confused with? That's normal in infants. GERD, right? So we have to really determine because parents are going to come in and anytime the baby vomits, it is projectile. Even if the baby, when it vomits, goes bleh, and it just kind of plutters down, they will say that that's projectile vomiting. If you have ever seen a baby projectile, it is like The Exorcist. They will open their mouth and they will hit the wall, okay? That is projectile. So when you ask the parents, because refluxers, my son refluxed so much. But it was just like, I mean, he would just, bleh, and like everything would just kind of come out. And I would be like, did he get any food? I'm not even sure because everything came out. It was not projectile. So sometimes parents get confused that the amount is the intensity. So try to distinguish that with them. Because what they're doing is the babies suck. They are starving. They suck. I want this food. I feel so hungry. And then it hits that mass and the body just kind of pushes it out. They have no pain. This is not painful for them, but they are hungry. They are hungry all the time because they aren't getting food. So if this goes on long enough, like let's say the parents think they're just refluxing, or they go to the pediatrician and maybe they don't describe it as projectile. Maybe they'd be like, my baby spits up a little after feeds. And they're kind of, sometimes, the parent's history is not so, I don't want to say the parent's history, but, we don't get a great feel for it. And this goes on for a week. The baby's going to start failing to thrive because they're not getting the nutrients that they need. They get dehydrated because it's a slow progression. It starts off normal and it gets thicker and thicker and thicker and thicker and thicker and thicker. So initially, they may just have a little like reflux, but it goes on for such a long period of time that they get lethargic. And they sometimes have this visible peristalsis. So you can actually see the stomach moving from left to right. And you can YouTube if you want to see it, but you'll actually see like a ripple effect or waves moving from the left side of the abdomen to the right side of the abdomen. And that's it's trying to force past that constriction. I'm going back. There you go. So they are like, I'm hungry. I want to shove as much food as I want down my face. And that's what parents will say. My baby always seems hungry, but they spit up everything after they eat. And that it's projectile vomit. If you get that in report, you've got to rule out GERD, but you have to really be thinking about pyloric stenosis. So oftentimes, even if we don't see anything on physical exam, because again, I never saw these two visible peristalsis and olive-like mass, I rarely saw, and we'd still get the ultrasound because it's so important to rule out. Because if we just say, well, I don't see these clinical manifestations, go home in a few days and see if it gets better, this baby can get really dehydrated and really sick fast. And remember, they don't have those compensatory mechanisms we do. So we'd rather get the ultrasound that's non-invasive, that's not going to hurt, and rule it out. And then once they determine that it is, if their labs are messed up at all, we're going to start IV fluids and get those corrected first, and then do surgery. And basically what we're going to do is go in there and cut out the thickened pyloric muscle, like kind of rotor-rooter it open. So it's a pylomyotomy. P-L-Y-O-R-O-M-Y-O-T-O-M-Y. For those who... So they make a little incision in the right upper quadrant. It's like this big. Or they do it laparoscopically, and they make a couple of little incisions. And they typically, whenever you have a laparoscopic surgery, you're going to get at least 3 incisions, but they're much smaller. There's one at the umbilicus, there's one above wherever you're doing it, and one below it. And that's because, have any of you got to see a laparoscopic surgery? They're pretty cool, aren't they? I got to do several appendectomies that way, and I would love it because we cut the appendix and I get to pull it through the trocar, it's called the trocar. And I get to pull it through, and it was like, and this little appendix would pop out. So they get 3 little incisions, and then they can do it that way also. They obviously recover much faster from a laparoscopic surgery than they do an open incision. So they have decreased surgery time, decreased feeding delay, decreased discharge time, and cosmetically they look much better, and they do much better pain. So when they do it laparoscopic, the big thing that people will complain about is they pump air into the belly so we can visualize things better. So post-op, they'll have a lot of gas, and gas pains can be pretty painful. So obviously we can't tell a baby to go ahead and toot. They're going to do it anyways. But when you have older patients, we can tell them that we really need you to pass gas because that's what's going to get the air out and help with their pain. But when we do an open incision, we manipulate the bowels a lot more. And anytime we manipulate the bowels, they kind of stop working. So we have to wait for the bowels to wake up before we feed them. And we call it RBF, return of bowel function. So if you ever hear that in the hospital, do they have RBF yet? That's what they're talking about. And they're listening for bowel sounds. So with a laparoscopic surgery, it doesn't take as long. The setup for surgery is longer, but the actual surgery itself is much faster. And because we're not manipulating the bowel pretty much stays awake. So as soon as they wake up, their bowel sounds pretty much are there. We can go ahead and feed them. And then they get to go home a lot sooner. We begin small, frequent feeds every 4 to 6 hours with glucose water first, because it's not unusual for them to still throw up after surgery. So we're going to continue the IV fluids. It almost becomes a habit, and their body's used to getting food and throwing it right back up. So even though we've gone in there and fixed the problem, we have to kind of retrain the body. So we're going to continue the IV fluids, start with glucose water first, and then move to breast milk formula. Now, this says after 24 hours. Again, the trend in the hospitals that you're going to see is that they're going to try to start normal feeds sooner and sooner. And just like with everything else, we want to hold them upright, feed slowly, and burp frequently. So we're not going to give them their 6 ounces of formula and let them suck 6 ounces down, because all they're going to do is throw that all back up. So even more than normal, we're going to give them 2 ounces, take the bottle out, burp them, we may even give them just an ounce at a time. But you really have to go very slow in the beginning, otherwise the vomiting is just going to keep happening and you're going to end up with all the same lab issues, metabolic issues. And then typically we have to take care of the operative site. Kids do very well with it, especially if it's laparoscopic. I mean, there's really almost nothing there. When they do laparoscopic surgery, often all that's left is a steri strip. They put like one stitch in a steri strip, and the stitches are typically dissolvable. So parents don't have to come back. They don't have to worry about follow-up as far as suture care goes. They just need to look for things, and we teach them. Is there any redness or discharge? Look for signs and symptoms of infection. But we tell them, I mean, babies aren't going, at this age, it's not like they're going swimming in a swimming pool or, tubing down the river or whatever. Hopefully not. So we want to keep them clean and dry. We tell them not to do a full bath until about a week or so when it's healed. And again, this says discharge home 2 to 3 days once they're on full feeds. If the baby's on full feeds within a day after surgery, they're going to send them home. They're not going to wait 2 or 3 days. The big things are their labs okay? And are they feeding without vomiting? Because if they continue to vomit, they're going to continue to have metabolic issues. Oh, we good?
Kind of a question.
Yeah.
So I wrote it down so I could get my thoughts.
Mm-hmm.
So I said, could a pyloromyotomy lead to colitis at the duodenum or further due to ulceration by means of the stomach acid leaking through the pyloric or weakened sphincter?
No. So you're worried, let me make sure I understand your question. So you're worried that gastric acid is going to leak through?
After they make the incision at the pyloric sphincter.
No, because it's not going to be accumulated, because they're going to throw up, when they throw up all their formula, they throw up all their gastric acid too. So it's not like that's just sitting there. It's not like, I produced gastric acid and I kept that, but I got rid of the formula. Everything goes out. And what they'll do is they keep these babies totally NPO, and they're typically NPO for at least a day or two with complete bowel rest. And for the most part, they won't have a lot of gastric acid because gastric acid is stimulated even by sucking on a mint or chewing gum. Those things will stimulate gastric acid, but as long as nothing's going in the mouth, then gastric acid really isn't stimulated.
I mean long term, from them making an incision?
No, because what they're doing is they're basically just roto-rootering it, because it went, it's a muscle, right? And your stomach's here, and it comes to a muscle that's leading to your intestines, and the muscle has just gotten smaller and smaller and smaller because it's not because the muscle's gotten thicker, and what they do is kind of go in there and kind of roto-rooter it open so that the thickened muscle is gone. So they don't have, it just becomes normal. They don't have, unlike the baby with EA and TEF that has to keep following up with the doctor long term, these babies, most of the time parents, you'll be like, have they ever had surgery? And they're like, no, never, because they're 15 years old. And you'll look in their chart and they're like, did they have pyloric stenosis? Oh yeah, I forgot about that. Because it happened so long ago and they have 0 complications from it. Because once it's opened up, it functions just like everybody else. Yep. All right, celiac disease. So the rest of them were kind of structural issues. This is a malabsorption issue. So it's an inflammatory disease of the small intestine, secondary to intolerance to proteins and gluten. And gluten is wheat, barley, rye, and oats. Wasn't Holland & Oates just here this weekend or something? I thought they were. Huh? It's typically diagnosed 1 to 5 years. It's inherited. inheritant. So if your family has it, you're more likely to get it. There's definitely environmental factors that influence it. And we often suspect it if the child eats well, but shows signs and symptoms of malnutrition. So everyone, I'm going to talk normal GI anatomy, right? So you have the little villi things in your GI tract, and as your food goes through, these little villi kind of pick up the nutrients, right? And they absorb them into the body to get used. Everyone's got that concept, all right? So when you have allergy, your body builds up that whole antigen-antibody complex, those immune complexes. And anytime gluten is ingested, the body's immune system reacts and recognizes it as foreign. So those antigen antibodies will come in, and those normal, healthy, long villi kind of get atrophied and inflamed and don't work. So now food is passing through, but no nutrients or vitamins or anything are getting absorbed because they're just kind of all inflamed and not working. So that's why when we rest our gut from gluten, then those villi can go back to normal and start doing their job again. What happens is that if you continue to expose them to gluten over long periods of time, the inflammation happens so much that they can die off and you can have sections that don't absorb. So you can have periods of exasperations because you get exposed to it, and once you healed, you're better. But if you keep re-exposing yourself, it's going to get worse and worse and worse. So my daughter actually has celiac disease. And I think some of you saw my kids when they came in. We just were measuring my children this weekend. My son is, because I told him they had to be 4'9" to get out of a booster seat. And we were talking about it this weekend. And my son is 4'8", and my daughter is still 4'6.5". And my son is 2 years younger than my daughter. So she's a little bit of a thing. And she actually diagnosed herself. I have a family history of it. I don't do great with gluten. I'm not allergic to it. I can tell when I eat it, I don't feel as good. I have a first cousin that's got it pretty bad. But I didn't even think about it because I eat plenty and good. But so she has always had, when she was little, had problems with headaches and constipation. And so we would give her Miralax a lot. And, of course, being in the medical field, I, of course, thought she had a tumor in her head every time she complained of a headache. And was, deathly afraid. Because she would get to a headache to the point where she would vomit. And as she got older, she started asking for different things. So she went to preschool at 3, and she said, "Mommy, I don't want sandwiches anymore. I want my meat and cheese rolled up." And I thought that's how her friends are eating their meals. And it didn't really dawn on me that anything was bothering her until we went to a birthday party, and somebody offered her a piece of cake, and she was 4, and she said, "No, I don't want any cake." And I'm thinking, well, I want the cake. Why don't you want cake? You should totally want cake. You're a little kid. And so I was like, "What's up, sweetie?" I was like, "Are you not feeling well?" Or, because you think, what kid's going to turn down cake? And she said, "Well, anytime I eat cake, that's when I get my headache, and that's when I get my tummy ache." And I was like, oh. So then we started watching, and we noticed that those were it, and we got her tested, and she got diagnosed with celiac. And it's a running joke at gymnastics because we can tell if she's been exposed because she can blow out the entire gym with her gas because it smells so bad. So you're going to see, you can think of my daughter, but they get impaired fat absorption, and they have these large, fatty, oily stools, and they smell atrocious. So my daughter used to, gosh, she'd be so embarrassed when she's older and hears these lectures. She's probably going to be already embarrassed right now. But she used to have stools like the size of her head, and I'd be like, my God, how did that come out of you? So, but these very smelly, large, foul-smelling stools because they're not absorbing any fat. They also have impaired absorption to nutrients. So their failure to thrive. They get muscle wasting, especially the legs and the buttocks. They're often anemic. They have a lot of abdominal symptoms like pain, distension, bloating, and anorexia. So because those villi aren't picking up those vitamins and minerals, they basically look like those little Caccicore babies. And I wish I could find, and it's so funny because again, in the medical field, you know, you think you know stuff, and then when it's happening to you, you kind of don't associate it. But I look back at pictures, and my daughter, when she was 2 and 3 years old, looks like one of those little, like, Ethiopian babies. She had, like, no arms, like, super, super skinny, and, like, a big old gut. So you guys know this kind of stuff because you're going to still have to remember it for your final. Their birth weight should do what by 6 months? And triple at 1 year. So my daughter was 7 pounds 4 ounces at birth. She was 16 pounds at a year of age. So she had barely doubled her weight. And we thought she was just small. So we came in and we like did a bunch of things. At that time we didn't get tested. And then she continued to grow, but she was always at like the 0 percentile. But on your growth curve, she was technically still on the growth curve and following it, just always really low. And we thought, you know, my husband's not very tall. We have some short people in our family. We thought she's just not going to be good, you know, big. But then as she started to grow, she would just have she had this big old belly and like these teeny tiny little arms and legs. Now looking back, I feel like I'm the worst mom ever. But they get behavior changes. They're not getting nutrients. You know, if you don't eat good, you don't feel good, right? So they're irritable often. And they can develop a celiac crisis. And this is a acute, severe episode of profuse watery diarrhea. And vomiting. So looking back with her headache, she was oftentimes not vomiting because of the headache, but because she was having celiac crisis. So she would vomit and vomit and vomit. And we thought she just had a GI bug or her head was hurting her so bad and she was vomiting just because of, you know, these acute crises. And they're often caused by some kind of stress on the body. So whether it's an infection or an emotional stress or something else. And when we, again, looking back, it's so easy to put the pieces together. But anytime she would get upset, this is when it would happen. So if she had like a tough day, she's my more anxious child. I apologize, she's more like me. She's a rule follower and she, you know, wants to make sure she's doing good and gets more anxious about things. And whenever she would get upset or anxious, this is when it would happen. And so we have to be careful because they're at risk of dehydration and developing that metabolic alkalosis again because they're just vomiting everything up. So we diagnose it by history and physical exam. Again, a lot of times, if the parents are like, I don't know, they're eating, and that was my daughter. She ate wonderfully. In fact, when she was only 16 pounds at a year, I had to go in every week to get her weighed for 3 months. And they would have her, and I was breastfeeding, so we would come in when she was time ready to eat. We would weigh her. I would feed her. We'd weigh her again to see how many ounces she was taking. And then they would, you know, do the whole exam. And we did that every time. And she was eating. She was like getting like 6 to 8 ounces every time she fed. So we knew, God bless you, we knew she was getting enough, but she just wasn't growing. We can do labs. They can get antibodies to the gluten, or if they're anemic, or if they're having any vitamin deficiencies. We can do a stool sample to test them when they're, see. They can do an endoscope, and that looks at the little villi that are in the intestine. And we can see whether they're all inflamed and damaged or whether they're working well. And a big diagnostic is, do they get better if we change their diet? So if we have them on a good diet, no gluten, wheat, barley, rye, oats, if they don't have any of that, and all of a sudden, they don't have fatty stools anymore, they don't have abdominal issues, they're not vomiting, they're not having any behavior changes, they're gaining weight and becoming nourished, and it's kind of like okay, that's our issue. So treatment, gluten-free diet, and this is very, very hard, okay? Now, there are lots of wonderful gluten-free products out there today, and there's gluten-free sections and all of that, but you would be surprised where you would find gluten. Gluten is in soy sauce. Gluten is in ranch dressing. Gluten is in, they're hidden in a lot of things, so you have to look, because they're not going to say, gluten as an ingredient. It's going to say wheat or barley or rye or oats. It's going to have one of those in there. Or it may be hidden. So unless it's like certified gluten-free, you really have to be careful. If it does not have that on there, there's a chance that there is gluten on there. We can tell the difference. My daughter has to have grass-fed beef and milk. And cheese, because if she has, and do you know how expensive that stuff is? Super expensive. Like I yell at my son if he drinks the grass-fed milk, because I'm like, no, don't drink that. You have that milk because it's way cheaper. So, but you have to, and we can only go to certain restaurants, because some restaurants, they serve a hamburger and if it's not grass-fed, she will immediately start getting symptoms. Within a couple of hours, you can tell that she's been exposed, because she starts having abdominal pain, she gets bloated, she'll get a headache. So a gluten-free diet. Now, when she was little, this was way easier. Thank God she was an easier, not a very picky eater, and she would eat whatever I gave her. As she's gotten older, it's getting a little harder, because she's going out with her friends, and all of her friends are eating things that look yummy and delicious, and she's really restricted. Now, thank God we have a great mommy support group, and they, are really good about having alternatives for her when there's parties and stuff, but it's really hard when we're talking about teenagers to have them follow a good diet. You can use corn and rice a lot as substitutes. But who wants to eat tacos with a corn tortilla when that flour tortilla is okay. Okay, bad example. Let me find something else.
Well, I have this. That's why.
Okay. They definitely need to be referred to a nutritionist, because they need a lot of dietary instruction. Again, unless you're familiar with it, you have to read so many labels and be so familiar with foods. And if you're not good at it, you definitely need guidance and help. Check labels, because things like malt, food starches, hydrolyzed vegetable oils, those are all gluten sources. So again, unless it says certified gluten-free, there's a chance that there could be gluten in there. They need lots of calories and protein, low-fat diet, simple carbs like fruits and veggies. And like I said, compliance is really hard with older kids. If they're not treated, the child may also have a lactose intolerance. So we can tell also that when my daughter has like a flare-up happening, she can't tolerate milk products either. They hurt her. During times of inflammation, you want to avoid high fiber foods. So again, normally we like high fiber, right? That bulks up the stool, that helps them go to the bathroom. If they're inflamed and having big fatty stools anyways, we don't need to bulk, okay? Trust me, if you ever saw my daughter's poop, she needed no problems with bulking, okay? So you avoid them during the times of inflammation, and then when everything subsides, then you can reintroduce it. You're going to treat nutritional deficiencies, iron, any vitamins, minerals. And again, that's mostly during times of flare-up. If they are compliant with their diet, they tend to have no issues. But again, it's that compliance or being accidentally exposed. Maybe they are very good about it, but they get accidentally exposed. Our goal is to prevent symptoms. And the big long-term complication is that they're at high risk for developing lymphoma, cancer. So that's the more that they are, the more that they're exposed and inflamed, the more their chance increases. So that's why we want to encourage them. Which one? Lymphoma. The goal is to decrease the risk.
Just say before a child may have lactose intolerance.
If untreated. So during times of flare-up, they often can't absorb. All right, any questions about that? All right.